Hello everyone. In this video, I'm going to continue talking about respiratory physiology. In our last lesson, we left off talking about the mechanics of essentially breathing in inhalation and breathing out exhalation. Today, I'd like to expand on that by talking about ventilation a little bit more, how we can make adjustments to it, what measurements we can take of ventilation, and how we can use those different measurements to diagnose restrictive and obstructive respiratory disorders. Furthermore, we are going to introduce the concept of external respiration. Right? So once the air has made its way into the lungs, we need to exchange oxygen for carbon dioxide. And so there are several physical factors that influence external respiration. We'll talk about these beginning today. So there are, of course, a lot of variations in ventilation, right? So how much air you're taking into your lungs and how much you're able to exhale out of your lungs. Essentially, we are constantly modifying how much air we are breathing in and out based on changing metabolic demands, right? So essentially, every time your heart rate goes up, you would expect your ventilation rate to go up as well. And so we can vary two different things. First of all, the respiratory rate, how many times we're actually breathing in and breathing out. In general, children take more breaths per minute than adults do. So on average, children is 18 to 20. A normal healthy adult at rest is about 12, right? So just like the heart rate gets lower if you are healthy, and so your breathing will essentially match that heart rate. And so if you're healthy and you're calm, you can essentially breathe fewer times per minute. If you take a look at an older textbook, you might see that it says that an average adult breathes fewer times per minute, and that actually is reflecting a change in our society. So, back in the day, many decades ago, individuals were much calmer. There was much less stress in the society. Essentially, one individual could support a household. Today, that's not really the case. Everything is go, go, go in our society now. And so the textbooks today say 12 breaths as opposed to 8 to 10, in the 40s and 50s. But now, if you were to take an average, you might even see even faster breathing. This is a concept or a phenomenon called chronic overbreathing or chronic hyper, too many ventilation, too many breaths per minute. And so again, this is very much linked to stress. It's linked to pathology. Poor diet can lead you to overbreathe. And ultimately, this is not only affecting the energy that goes into inhaling and exhaling, but it also changes how much carbon dioxide is in your blood. And as we're going to see in our next lesson together, it's really important to maintain carbon dioxide levels, even more important than oxygen levels, according to our body, in order to maintain proper functions in our body. And so the fact that we have this lack of carbon dioxide in our blood, which we'll get into a little bit today, this actually is linked to a lot of the normal aches and pains and just kind of like feeling that many of us experience on a daily basis. Okay. So again, we're talking about how we can change ventilation in order to meet our metabolic demands. We can change how many times we breathe in and out, and we can change how much air we're taking into our body. Now, you sitting there right now, calmly listening to this lecture, are without even thinking about it, even though now you are, without even thinking about it, you are inhaling and exhaling about 500 milliliters of air in and out and in and out. Very calm. You're not using your internal intercostals. You're only using your external intercostals in order to take that inhale and passively exhale. And so as we see down here, the volume of air in our lungs goes up a little bit, and then we exhale. Then we inhale, and then we exhale. And again, at rest, we are essentially moving about 6 liters of air every single minute. Some other factors that we can measure the respiratory minute volume. So essentially how much air we're moving into and out of our lungs per minute. Again, at rest, this averages about 6 liters per minute. And of course, if you are a chronic overbreather or chronic hyperventilator, this is going to increase substantially. We can measure not only the tidal volume, right? So the 500 milliliters that comes into and out of our lungs in a normal quiet breath, but we can also measure a series of other what are called volumes, right? So this is done with a tool called a spirometer. And down here, this is like the super old school version of a spirometer. You essentially blow into this this little tube here, and the little float goes up, and you can actually measure how much air you are exhaling in a given breath. So we're going to take a look at some data obtained from the newer versions of these. Today, we use a little bit more technologically advanced spirometry machines. So this is still pretty simplistic. Usually, if you are having a spirometry test done either in Stockton's lab or at the clinic, you breathe into a tube that's connected to a computer, and that graphs the data for you. And so we are going to take a look at some of that data that has been graphed. And so specifically, the spirometer is measuring the volumes that are coming into your lungs, the volumes that are going out of your lungs, and we can actually add those different directly measured volumes together to produce what are called capacities. Okay, and so all of these are really important to obtaining a clinical diagnosis. Let us watch this video together now. She does a great job of explaining all of these different inhales, exhales, and the names that we are going to be using for the rest of this unit.
In the previous video, we talked about lung volumes and capacities. Today, we're going to take a closer look at them. As we mentioned previously, lung volumes and capacity is measured by spirometry. The first thing that we're going to take a look at is called the TLC, or the total lung capacity. Total lung capacity is the amount of gas in the lungs after a maximal inspiration. So if you take a deep breath in and hold it, the volume of gas in your lungs is the total lung capacity. Normally, it's 6 liters for adult males and 4.2 liters for adult females. Next, we're going to take a look at vital capacity, or VC. Vital capacity is the amount of gas that can be exhaled after a maximal inspiration. So what you do is take a deep breath all the way in and then blow it all the way out, and that would be your vital capacity. The residual volume is the amount of gas remaining in the lungs after a maximal expiration. So as you're sitting there and you blow all the way out as far as you can, the amount of gas that remains in the lungs is the residual volume. Normally, it makes up 20% of the total lung capacity. Vital capacity plus residual volume equals total lung capacity. Tidal volume is the amount of gas an individual inspires or expires during normal, quiet breathing. So as you sit there breathing normally in and out, that's your tidal volume. It is 7 to 8% of the total lung capacity. The inspiratory reserve volume is the amount of gas that an individual can inhale above a tidal inspiration. So as you're sitting there and you make a normal tidal inspiration and then take a deep breath all the way in as far as you can, that's your inspiratory reserve volume. Normally, it's 60% of the total lung capacity. The expiratory reserve volume is the amount of gas that an individual can exhale beyond a tidal expiration. So as you're sitting there and exhale normally, and then push all the gas out that you possibly can, that's your expiratory reserve volume. Normally, it's 20% of total lung capacity. Tidal volume plus inspiratory reserve volume plus expiratory reserve volume equals vital capacity. FRC, or the functional residual capacity, is the amount of gas remaining in the lungs after a tidal expiration. Normally, it is 40% of the total lung capacity. There are three different types of capacities. The first is the lung capacities. It includes inspiratory capacity, which we're going to discuss next, the functional residual capacity, vital capacity, and total lung capacity. The inspiratory capacities is the amount of gas that an individual can inhale starting at a tidal expiration. So as you breathe out normally and then take a deep breath all the way in, that's the inspiratory capacity. Therefore, it includes the tidal volume and the inspiratory reserve volume. For instance, it would be smart to take an inspiratory capacity before jumping in water so that you can stay underwater longer. Normally, it is 60% of the total lung capacity. And finally, going back to the functional residual capacity, this cannot be measured directly with spirometry because the residual volume, or RV, cannot be exhaled. The functional residual volume is measured indirectly using helium dilution or nitrogen washout. The functional residual volume includes expiratory reserve volume and the residual volume. Thank you for tuning into Biology Made Simple. Please don't forget to subscribe.
Okay, so she talked about a lot of different volumes and capacities. Your job is to be able to look at a spirogram, right? This graph, this reading out of the computer as the patient is breathing in and out into the computer. So you should be able to take a look at this and recognize that this here is normal old tidal breathing. This is blowing out as much air as you possibly can until you feel like you're completely deflated. This here is taking a super deep breath as if you are going to jump into a pool and want to hold your breath for a long time. And then here we can see the vital capacity. This is the entire volume of air that is able to be exchanged with the outside world. No matter what you do, no matter how hard you blow, as long as your rib cage and your lungs are intact, there's always going to be about 1 liter to 1.2 liters of air still left in your lungs, right? So literally from the very first breath you take, you are always going to have a little bit of air left over in your lungs. Certainly the air that's in your lungs right now is not the same air as the first breath you took. It's constantly being mixed and exchanged, but no matter what you do, there's always going to be a little bit of some left over. Okay, so again, you should be able to recognize a spirogram and tell me what all of these different volumes and capacities are. And so I also want to point out that on the video, she didn't include units on the y-axis, but this particular graph does have units. It is in milliliters. In order to talk about the liters, just move the decimal point over 3 spaces. So this is 1.2 liters, this is 2.3 liters, 2.8, and all the way up here is 6 liters. And just throwing it out there. That's what those mean. Okay, just another way of showing you all of these different things. All of these funny little blocks right here are showing you that the FRC, the functional residual capacity, is equal to the ERV and the RV. The residual volume plus the vital capacity is the total lung capacity, right? And so on and so forth. And so here are also some values for you to be able to recognize for males versus females. It is not critically important to memorize all of these to be able to spit them back up at me on a test, but you should be able to recognize that normal tidal volume is 500, right? 1/2 liter no matter what. You have about 1 liter to 1.2 liters left over in your lungs. And so this is really important because if there's a lot more than this, that means something. If there's a lot less than this, that means something. Okay, also another one to recognize, You know, you can memorize these numbers, right? So about 2 to 3 liters for the IRV, but also we can look at the spirogram, and essentially if the spirogram is way up here instead, that means something. Okay. And so we can, of course, measure these different volumes and capacities. We can measure the volumes and calculate the capacities. And as we are kind of building up to here, each value that we can measure or calculate actually can help us to determine if the patient is experiencing one of a couple different types of respiratory abnormalities. There are a few additional endpoints that we can measure, and the next one here is forced vital capacity. So remember, vital capacity is just the amount of exchanged air, right? So your deepest inhale, your deepest exhale. So FVC is the amount of air that is forcefully expelled after taking a deep breath. Okay, and we can forcefully exhale for different periods of time. And so that's where FEV comes in. If you are blowing as hard as you possibly can, we can measure how much air actually got out of your lungs in the first second. And so if you remember back to our last lesson together, I told you that there's 2 different types of disorders. One is a problem with inhaling, the other is a problem with exhaling. And so if your problem, your respiratory issue is with exhaling, then you're not going to be able to get out as much air within that first second, right? Maybe if you keep blowing and blowing and blowing, you'll be able to get out the appropriate volume, but it's going to take a long time. Okay, let me play this short clip for you that is on COPD. It is one of these types of disorders, and it's going to show you how these different volumes and capacities can shift in a patient with this type of disorder. Then we'll come back together and we'll talk about the different things that we can measure.
Chronic obstructive pulmonary disease, pathophysiology and diagnosis. Cigarette smoking is by far the most common primary risk factor of COPD worldwide. According to global statistics, approximately 210 million people have COPD. By 2030, COPD is predicted to be the 4th leading cause of death worldwide. Epithelial cells lining the airways will respond to smoke inhalation by undergoing cellular changes due to long-term exposure. Over time, chronic irritation and inflammation of the air passages causes small airways disease and parenchymal destruction. Irritation and inflammation of the air passages causes constriction in the bronchi and bronchioles of the lung. In a healthy individual, standing at rest at the foot of a staircase while breathing normally, lung volume is well balanced in terms of IRV, inspirational reserve volume, VT, tidal volume, FRC, functional residual capacity. In the severe COPD patient, lung function is extremely imbalanced with only a tiny capacity for IRV. A patient with severe COPD has a very difficult time managing everyday tasks, such as stair climbing. The patient is asked to inhale and then forcefully exhale until the lungs are completely emptied via a tube attached to a recording device. The most important values from the spirometry readings are FEV1 and FVC. If the ratio of these values is less than 0.7, then COPD is suspected. More detailed results from spirometry can reveal the stage of COPD in the patient.
Okay, so just a note before we move on to the next slide. TV and V sub T both mean tidal volume. Another note, it's I think the video did a great job of showing you guys that the reason that you need this inspiratory reserve volume isn't just so that you can take a super deep breath to dive into a pool, but also when you start to exert yourself physically, there is actually a lot of extra space in your lung that you're not actually using on a regular basis that you can utilize to get enough air in so you can oxygenate your blood, which is of course being pumped much more quickly, with much more pressure, to ultimately deliver oxygen to your tissues. Okay, so if you have COPD, as you saw, air is actually trapped in your lungs. And so it's taking up a lot of that extra space, but it's not actually doing anything for you. And so when you go to climb the stairs or go for a jog, all of a sudden there's not any more room within your lungs in order to match the needs of your body at the time. These spirometry tests can help us to distinguish between obstructive pulmonary imbalances or disorders, just like COPD, as opposed to restrictive pulmonary disorders. Okay, so remember from our last lesson together that obstructive pulmonary disorders are a problem with exhaling. Right? Increased airway resistance essentially lets you pull air in because inhaling is the active part, and so you can pull air past all of that extra mucus, all of that, then your narrowed airways, but then because the exhale is the passive part of this process, it's really difficult to actually get all of that air back out. And so you might see that your lung capacity might even get bigger, right? Because you are actually taking tons and tons of air into your lungs because you can physically pull it past those obstructions, but you can't actually use a lot of that air. Okay, so your vital capacity, right? The amount of air that you can actually utilize and exchange with, your biggest inhale and biggest exhale, the most important one as far as just living your life is concerned is IRV, right? You can't increase how much air you're taking into your body when you need it, when you need to climb the stairs, when you need to run away from a bear, right? So IRV will go down. And expiratory reserve volume, remember, exhaling is the problem. So you're not going to be able to actually get all of that extra air out of your lungs. And so what we see is that there is a lot of air left over, and so your residual volume is actually going to increase. Okay, and so if you were to look at a spirogram for an obstructed lung, you would see that this entire set of waves here goes up. Okay, we'll look at that here in just a moment. On the other hand, contrast this with restrictive pulmonary imbalances. Remember that this is some kind of a structural issue which is preventing you from inhaling. Right, so tuberculosis, fibrosis, a broken rib, right? Every time you take a breath in after you break your rib, it hurts a lot, right? And so you don't really inhale as much because you don't want to move your ribs quite as much. And so you're not going to be inhaling. And so your total lung capacity, right, how much air you can take into your lung, is going to go way down. Okay, this also results in a reduction in vital capacity, right? So if you're not taking as much air in, you're not breathing as deeply, you're just taking these tiny little shallow breaths, you're not going to be exchanging as much air, and therefore you can't, well, your vital capacity goes down, right? Your residual volume goes down, pretty much everything decreases in a restrictive pulmonary disorder. Again, as opposed to an increase in residual volume and a decrease in vital capacity and IRV in particular. Okay, so here are 3 different spirograms. Again, you should be able to recognize what are approximately normal volumes here, right? So the total lung capacity, TLC, is about 6 liters in a normal healthy individual. We constantly exchange 500 milliliters with each breath, so tidal volume good to go. And there's, about 1, this one is showing 2, but just to exaggerate the point here, anything more than 2 is just no good. And so here is asthma. And if you were to guess what asthma is, you could immediately say, oh, that must be obstructive because we see a residual volume much larger than normal. We can see our tidal breaths are way up here. So you're still exchanging, give or take 500 milliliters, but your IRV is very much depressed. Another thing that increases is your total lung capacity. So you might be able to breathe in, but it's breathing out. That's the problem. Same thing with emphysema, and we'll talk about here more in a little bit. But emphysema is an obstructive disorder, right? Because we see a drastic increase in the residual volume. We see a slight increase in the total lung capacity, but at what cost? Well, the cost of the IRV. Okay. Finally, on the other side of this coin, we have fibrosis, so scar tissue from breathing in something like asbestos for a long period of time. So if you're a construction worker, or if you live in an old house that has a lot of asbestos around, you haven't gotten that taken care of, and you're always interacting with it, those little fibers are airborne. You're breathing them in and your lung can't clear them. And so they actually kind of embed themselves within your tissue. And every time you breathe in and out, which of course is a lot, they are scratching at the inside of your lungs, and they're going to leave a lot of scar tissue. The thing about scar tissue is that it's not contractile and it's not very stretchy, right? So over time, your lungs aren't going to be able to expand quite as much as they should be able to. And we can see that pretty much everything is decreased in this restrictive pulmonary disorder. Okay, so again, here's just another chart that is showing us what test we can use or what tool we can use, the different things that we can measure. We'll talk about gas diffusion here shortly, but I bring this up now because, of course, you should be able to look for all of these different volumes and capacities within a spirogram on an exam. But also, the video did mention that the clearest test for diagnosing an obstructive disorder is FEV1 over FVC. And so anything less than 80% indicates an obstructive disorder. Okay. So shifting gears just a little bit, we have been talking about ventilation. So getting air into your lungs, getting air out of your lungs. And of course, there are a few pathological conditions that will prevent either the inhale or the exhale. Now, let us assume that we have air in our lungs. Okay, so then what happens? Right? So in order to continue our conversation about external respiration, exchange of gases in our lungs, we first need to talk a little bit about Dalton's law of partial pressures. Now, every breath you take is not just pure oxygen, of course. It is, in fact, a mixture of oxygen, nitrogen, carbon dioxide, water, and all sorts of other things, good or bad. And so that atmospheric pressure we talked about in our last class together is actually a sum of the pressures of all of those individual gases. That is, every single gas, oxygen or CO2 or nitrogen, they all exert their own pressure on our bodies, on our lungs, on, our house, right? Whatever. They exert pressure on everything. And so as we can see over here, the pressure of this particular red gas and the pressure of this particular blue gas ultimately add up to be the total pressure of the air that these two gases are making up. So again, the atmospheric pressure is the sum of what we call the partial pressure of oxygen, right? The partial pressure of nitrogen, right? Sub gases, right? Partial pressure of water, and so on and so forth. Now, if we take a look at over here, we see that the air we breathe is actually mostly nitrogen. Right? There really is only about 20% oxygen that we're breathing in, right? So that'll be important here in just a moment. And we are actually breathing in carbon dioxide, right? So even though our body is trying to get rid of the carbon dioxide, we still are taking in anything that's in the air, right? These gases or particulates or viruses or whatever is in the air around us is going to come into our lungs. We have all of these different filtration mechanisms, right? The mucus and whatnot, but pretty much what's in the air, you are inviting into your body. Okay. And so I bring this up because each individual type of gas, nitrogen, oxygen, carbon dioxide, whatever, is going to move according to its concentration gradient, right? So we've been talking about these whole pressures, atmospheric pressure versus intrapulmonary pressure, and the gas itself, right? The whole sum of air comes into our lungs or out of our lungs based on the difference in pressures. Here, we of course are going to be talking about gas exchange over the respiratory membrane. So here's an alveolus, here is the blood flowing through the capillary around it. And so each individual gas is going to move down its concentration gradient or its partial pressure gradient. We never want to use active transport for these processes because we want them to be super efficient. They don't have to wait in line or wait for energy to be converted into ATP and then pumping, any of that kind of stuff. No, these gases are sliding right in between those phospholipids over the membranes of the alveolar membrane, the capillary membrane, the red blood cell membrane, and ultimately into your red blood cells. Okay, and so if we think back to the previous slide, I showed you that about 20% of the air is oxygen. We know that oxygen is about 750 millimeters of mercury at sea level, so where Stockton is. And so if you do the math, roughly 150 millimeters of mercury is the partial pressure of oxygen. And so as you are inhaling right now, you are taking in this particular partial pressure of oxygen. So about 150. Okay. Now, as the air descends through your bronchial tree, through your respiratory tree. As I mentioned in our last class together, the air is kind of modified a little bit, right? I told you that the air is warmed, right? We don't want to be taking in, 15-degree air from outside into our very delicate, very thin, and of course, very wet alveoli, right? That will freeze them, and that's certainly not ideal. And so the air is warmed up on the way down. And moisture is added, right? So we humidify that air, okay? Also, remember that we always have a residual volume or even a functional residual capacity of air that is left over in our lungs, right? As long as our lungs aren't completely flattened like a cartoon, right? Completely flat like paper, there's always going to be air left in our lungs. And so there is no physical separation between the new air coming in and the old air that's kind of hanging out from your last breath, except in birds, but we're not birds. So there's this mixing of the new air and the old air. Okay, so remember that the old air has just had oxygen dumped into the blood, and therefore there's going to be less oxygen in the old air than there is in the air coming in. And so after all of this mixing and humidifying and warming and all of these different processes have occurred, we're left with about 105 millimeters of mercury of oxygen in our lungs. And again, that's at sea level, right? Not higher in altitude. Okay, so at the respiratory membrane, we have these partial pressures of oxygen and carbon dioxide, right? And so remember that all of the gases are going to diffuse according to their partial pressure gradient, right? So both flow down their partial pressure gradients, and of course they have to flow over the membranes of the alveoli, over the membranes of the capillaries, over the membrane of the red blood cell, right? So lots and lots of diffusion happening. And this is why we can't just wait around for active transport. We need this to happen right away. And so this is simple diffusion. this process of external respiration is influenced by 4 different physical factors that we're going to talk about. The first one is these partial pressure gradients. Okay, and so as I said on the previous slide here, oxygen in our lungs is at about 100. In our blood, returning from our tissues after dumping off tons of oxygen, it's at about 40. Okay, so 100 is much greater than 40, and so oxygen is going to diffuse this way into the blood out of the air. On the other hand, carbon dioxide is 45 versus 40 in the air, right? Remember, there was lots of mixing happening. And so this is still higher than in the air, and so carbon dioxide is going to, again, diffuse out of the blood into the air, and then we can exhale it. Okay, so really important to maintain these partial pressure gradients. This is the same exact thing actually that's happening in internal respiration, right? So when gas exchange is happening with our tissues. Okay, the next physical factor that's affecting external respiration is the respiratory membrane itself. We've briefly mentioned little bits of this before, but I want to emphasize that that really thin respiratory membrane must remain really thin, right? So the fact that I'm emphasizing that means that there are things that can go wrong that make that membrane not quite so thin anymore. Okay. Also, this respiratory membrane must be covered with water, right? With water, with mucus. As I've said before, in order for external respiration to occur, oxygen and CO2 have to be able to dissolve in that water, in that moisture. Okay, so respiratory membranes must remain moist, and there has to be a huge surface area, right? So relative to the size of the body, our lung surface area, the respiratory membrane surface area, is just massive. Okay, the next 2 factors are the solubilities of the gases, right? If oxygen and CO2, et cetera, have to dissolve before they can diffuse, the solubilities of those different gases is going to be important. And finally, a process called ventilation perfusion coupling. And so this is essentially matching of the flow of blood with the exchange of air into and out of your lungs. Okay, so just to emphasize this point a little bit more, respiratory membranes have to be super thin, like super thin. The total surface area of our respiratory membrane, so alveoli, alveolar ducts, as well as respiratory bronchioles, is 40 times that of our skin, right? So very, very high surface area, and there must be this layer of moisture. So there's a layer of fluid, and as we know, this is due to the secretions of the type 2 pneumocytes or alveolar cells. Okay, so as I mentioned, if I'm emphasizing that the membrane has to be thin and moist, there has to be something that happens that changes that prevents that, right? And so this is one example of when the respiratory membrane changes in the respiratory membrane can ultimately lead to less respiration, less gas exchange. And so if we look at this word, edema should stand out. So we know that edema is swelling. And so in this particular case, heart failure, which we talked about in a case study before, has led to swelling within the lungs, right? So, or not swelling in the lungs, it has led to fluid buildup in the lungs. So if we look at this flow chart here, we can see that there has been decreased stroke volume because of a problem with the left myocardium, the left wall of the or the left ventricle wall, and therefore, you know, over all these different things, this leads to less efficient pumping of blood out to the body, and so more blood is kind of hanging out in the lungs because it can't actually flow through the heart. And then finally, this, you know, prevents efficient gas exchange, right? And so gases travel through the thicker space, right? Because there's so much extra fluid here, and this leads to an oxygen deficiency, right? Just because the gases have to spend so much time diffusing as opposed to this nice little thin layer of moisture, which doesn't take any time to diffuse through. Another way that we can affect the respiratory membrane structures and therefore affect external respiration is through obstruction in your airways. So the video that I showed you earlier in this lesson mentioned COPD. And so emphysema is, of course, linked to COPD, essentially after many years of inhaling these particulates and, of course, the cilia trying so very hard to move all of that very thick, gloopy, tar-filled mucus up and out of your respiratory tract, and so that you can swallow it. Eventually, they become a little bogged down. They don't really work as well anymore. And so all of that mucus with that gunky tar and smoke and all sorts of lovely carcinogens is going to get stuck in your smaller airways. And so this, of course, is an obstructive disorder. And the problem here comes, another problem here is that, of course, when you inhale, you can inhale past the obstruction, but it's really hard to exhale past the obstruction. And so old air, right, the previous breath gets stuck in your alveoli. And of course, you're still taking in new breaths. And so they're going to stretch and stretch and stretch. And so this excessive stretching without any recoiling ultimately leads to the breakdown of the alveolar membranes. Okay, and so this process is, or this breakdown is kind of treated by your body's natural inflammatory response. But while that is, kind of has the best intentions, right? It's trying to fix your damaged tissue, which is a good thing. It's actually making the problem a little bit worse, right? Because now you have even more inflammation, you have more obstructions in your airways, and so it's even harder to get air to flow back out. And so, of course, this inflammatory process just makes it worse. It can't keep up. And so over time, those membranes break down entirely, leaving your alveoli to kind of open up to one another. So alveoli coalesce. And this is a problem because we like all of the surface area, right? This entire thing is a respiratory membrane. This entire thing is a respiratory membrane. And so is this. And so that is really efficient for gas exchange. But if we start to break those membranes down, now we have lost all of these opportunities for oxygen and CO2 to cross over into and out of the blood. And so emphysema, in addition to being an obstructive disorder, can lead to a reduced surface area and therefore reduced respiration. Yeah, one final thing. With a lot of these conditions, with many conditions, there may be a need to remove part of or an entire lung. And so particularly in cases of lung cancer, an entire lung can be removed, an entire lobe can be removed, a segment. Remember that a lot of clinical conditions are isolated to one or a few of those segments, or even just a small wedge. And so obviously, if you are taking out this entire piece of lung, now you have just lost all of that surface area available for gas exchange. And I show you these pictures because I hope we can all appreciate just how far medicine has come over the years. This here is how they used to remove lungs or do surgeries on lungs. Essentially, you have to remove the entire section of the ribs in order to access the lungs. Of course, this will greatly increase healing time and be very, very painful. Now, many of these surgeries can be conducted laparoscopically, so just with a few small incisions without actually having to remove the ribs and the skin and the muscles and everything to get to the lungs. So go science. All right. Third factor affecting external respiration is the solubility of gases. Another law to talk about, and this is Henry's law. Henry's law states that as the solubility of a gas in a solution increases, as the partial pressure of the gas above the solution increases, right? So let's see what that's all about. Here we have gas molecules, right? Maybe this is oxygen in the air above a fluid, right? So we're talking about the solubility of these oxygen molecules, for example, into this water, for example. At low atmospheric pressure, the oxygen molecules, not to anthropomorphize, but they're going to be pretty comfortable just hanging out in the air. All right, so they're not going to be very soluble in water as long as there isn't a lot of pressure kind of pushing them down into said water. As the pressure outside the water increases, right? So here we see the volume of air is decreasing, therefore the pressure increases, right? We talked about that before. And so this extra pressure is kind of like pushing the air into the water. Okay, and so it becomes oxygen is going to become more soluble in water because of that extra pressure in the air above it. Okay, so what are the implications of this? Well, to appreciate this, you can think to opening a can of soda, can of beer, whatever, your carbonated beverage. And essentially, it is carbonated fluid. Therefore, there's carbon dioxide, which is forcefully pushed into your beverage of choice. And so the can, as long as the tab isn't popped, is going to have all of these little bubbles, these gas molecules dissolved in the fluid. Now, as soon as you pop the top, you are drastically reducing the pressure in that can. And what that's going to do is it is going to, it is going to reduce the solubility of carbon dioxide, and therefore the CO2 is going to very rapidly come out of the of your drink and back into the air, right? So this is the high pressure situation where CO2 is kind of forced into that fluid, and here's the low pressure situation where the gas molecules are freed into the low pressure air. Okay, so in the human body, this kind of same thing happens in something called decompression sickness, or more commonly called the bends. Essentially, when you and your body go from a very high pressure environment to a much lower pressure environment, some of the gases that are kind of pushed into your blood, they are dissolved into your blood, they are going to be liberated because now they are less soluble in your plasma, and they are going to form bubbles and kind of come out into the air. And so that's a little difficult when, of course, your blood is in your body. And so where do these bubbles go? Well, essentially, they are going to accumulate in your joints. They're going to accumulate in other tissues. This is, of course, very uncomfortable, and it can be fatal. And so generally, scuba divers who are coming to the surface have to stop at various increments and coming up so that they can not essentially pop the top on their blood and release all of these all this nitrogen gas into their joints, but instead slowly release these gases in a controlled way. Okay. So scuba divers coming to the surface, pilots in unpressurized cabins, right? So going from atmospheric pressure around Stockton and then going up thousands and thousands of feet into the air, that can also lead to the bends. And certainly don't go in a plane right after you are scuba diving, right? That's pretty bad. Okay, so why the heck am I talking about this now? Well, gases in general have different solubilities, right? So in addition to the fact that the pressure of the gases in the air is going to determine how much they are going to dissolve in the water of your lungs, for example, gases themselves also have different solubilities. Okay, in general, CO2 is about 20 times more soluble in water than oxygen is, right? So CO2 has no problem going into your beverage of choice. Oxygen, on the other hand, needs to be kind of pushed a little bit more. So it takes a higher pressure in order to get oxygen to dissolve in the fluid of your lungs, in water, in your plasma. Okay, and so this graph here is showing you just the differences in solubility of these two gases. If you're interested in learning more about this, here is a link to a Khan Academy video that explains this in more detail. What we need to know for this class, however, is that between Dalton's law and the different solubilities of gases, CO2 versus oxygen, this means that diffusion of oxygen requires a much steeper gradient, so a little bit more coercion than the carbon dioxide concentration gradient, or partial pressure gradient, that is. If you remember, a few slides ago, we saw that in the air of our lungs, oxygen has a partial pressure of about 100 versus in the blood about 40. Right, so that's a very steep partial pressure gradient. CO2, on the other hand, only has a difference of about 5 millimeters of mercury. So that's hardly even a partial pressure gradient. But because CO2 is so soluble, that's enough. Okay. The other implication of this is that oxygen, as you know, has to be carried by hemoglobin. Right? Oxygen really doesn't like to just hang out in the blood, which is, of course, mostly water. Instead, oxygen has to be bound to something. Okay, and that something, of course, is hemoglobin, and we are going to talk about, all the different enzymes and everything that makes that happen. But for now, oxygen has to be carried because it doesn't really like to be in water terribly much. CO2, on the other hand, can dissolve in your plasma pretty readily, and so there are actually a lot of different ways that CO2 can be transported. Right, it can actually bind to hemoglobin in another spot. It can just hang out in the blood, just plain, and it can become part of that buffer system that we talked about kind of on the first day of class, right? So this bicarbonate carbonic acid buffer system, CO2 plays a huge role in that, and that is where the respiratory system comes in to pH balance. To be continued. Okay. The fourth and final factor influencing external respiration is a phenomenon called ventilation perfusion coupling. Ventilation, as we know, is breathing, and perfusion we talked about with the cardiovascular system. This is essentially the flow of the blood, okay? Specifically the flow of the blood through this lung tissue in this scenario. Essentially, in order for ideal external respiration, ideal gas exchange, we need to match the flow of air with the flow of the blood. Okay, and so we already kind of appreciate this, right? When you stand up after listening to this lecture and you start walking, all of a sudden your heart rate is going to increase, right? And therefore your cardiac output increases. And so now you have more blood flowing through all of your tissues, right? Ultimately feeding your skeletal muscles, but also flowing through your lungs. Okay, and so we don't just have an increased heart rate, we also increase the rate of our breathing, our ventilation rate, right? And so we can already appreciate how whatever the heart does, the lungs kind of have to do as well. Okay, and so we match the ventilation perfusion at a particular ratio, right? This is the ideal ratio. Generally, normal ventilation, give or take 4 liters of air per minute, and normal perfusion, so blood flow, is about 5 liters of blood per minute, right? So remember that cardiac output is essentially circulating the entire volume of the blood every single minute. And we exchange about 4 liters of air in our lungs per minute. And so the normal ventilation to perfusion ratio is 4 to 5 or 0.8. All right, so let me just point out that ventilation is V, perfusion, we're talking about all sorts of like pressures and stuff, which all start with P, so perfusion is Q. So a VQ ratio is 4 over 5 or 0.8, right? So that is healthy matching of breathing and blood flow. So what happens if there is a decrease in this ventilation perfusion ratio? Okay, so the decrease in this ratio, so less than 0.8, can be a result of decreasing how much you're breathing, right? So hypoventilation. Hypo is less than, ventilation breathing, so less breathing than is adequate. Or it can be increasing the blood flow, right? So either you are decreasing the numerator or you're increasing the denominator. Both of them are going to result in a ratio that's less than 4/5. Okay, and so what would happen if we decrease the amount of air that's coming in or increase the amount of blood that's coming in? Essentially, this is going to lead to less oxygen, right? So we're not taking as much air in. So now we're not going to have as much oxygen in our alveoli to give to our blood, to give to our tissues. Okay. The other thing that's going to happen here is that carbon dioxide is going to increase, right? So if we are not, for example, breathing as much as we need to in this particular scenario, not only are we not taking in as much oxygen as we need, there's also not as much of an opportunity for carbon dioxide to leave the blood, enter the air, and be exhaled. Okay, so a decrease in VQ ratio results in less oxygen and more carbon dioxide. On the other hand, an increase in VQ ratio, right? We can either increase the numerator, increase how much you're breathing, or we can decrease the denominator, right? So stopping or reducing blood flow. Okay. Note that increasing ventilation is hyperventilation, hyper more than, above. So this is too much breathing. Right, so if there's an increased VQ ratio, we can expect that the alveolar levels of oxygen are going to increase, right? You are taking more air into your lungs, and therefore you might imagine that there's going to be a little bit more oxygen in your lungs. On the other hand, carbon dioxide is going to decrease, right? So with every breath that you take out, you are taking more and more CO2 and you are exhaling it. And so now the carbon dioxide levels in your blood are going down and down and down because of this excess in breathing or decreased blood flow, right? It could be either problem. And so if you remember from the cardiovascular system, we talked about chemoreceptors and how they're always kind of monitoring CO2 and hydrogen and a couple other things. I told you that carbon dioxide is, or low carbon dioxide is the strongest stimulant of the cardioacceleratory center, of the breathing, right? So your body is going to try to compensate for this lack of carbon dioxide by breathing more, right? Or sorry, more exhaling of CO2 is going to decrease carbon dioxide. And as a result, this is going to lead to some pretty big changes in your body. And we are definitely going to get into that. And I will be much clearer about that, I promise. Okay, now I want to elaborate on this decrease in carbon dioxide. So that's what the stars are for, by talking about what the paper bag is for, right? So when you are hyperventilating because you are, upset, you're having an anxiety attack or something, they tell you, right, to breathe into a paper bag. So really, what the heck is that all about, right? So we know now that hyperventilation causes a reduction in carbon dioxide. Right, CO2 levels are really what the body cares about, even more than oxygen, as far as regulating breathing and heart rate. Okay, so with less carbon dioxide in the lungs and then ultimately less carbon dioxide in the blood, what this does is it leads to a higher pH, right? So your blood is going to become slightly alkaline because there's not enough CO2 because you're just breathing it out so quickly. Okay, so you are breathing into the paper bag, right? Because as you exhale that CO2, what little CO2 that you have left, what your body is making now, you are breathing that CO2 back in, right? So this is called rebreathing. And so you are increasing that alveolar carbon dioxide once again. And so this is going to bring your CO2 levels back up in your blood, and it is going to bring your pH back down to normal. And so to stop breathing into the bag, when essentially your blood vessels, your veins, your arteries, they feel kind of like they're burning, right? So once you have brought your pH down so far that it feels like there's kind of acid in your vessels, that means you're good to go. If you don't breathe into the paper bag, you risk passing out, right? So passing out is essentially the the ultimate stop to your hyperventilation, because you will automatically resume normal breathing when you pass out. Though, of course, that's not ideal. You should try the paper bag first. Okay, so clearly ventilation and perfusion coupling is really important. Any shifts in blood flow has to be matched with a shift in breathing. And so this is yet another example of what is called autoregulation. Remember that our blood vessels, and as we see here as well, our airways, our bronchioles, automatically adjust based on the needs of the tissues. Okay, and so this graphic here is showing us that if there is decreased airflow, right, essentially blood flow is going to be decreased to match it. If there is increased airflow, blood flow is going to be increased to match it. And of course, vice versa. Okay, so our body is constantly matching breathing and blood flow to maintain this 0.8 VQ ratio. As you might imagine, there are conditions that shift this VQ ratio to be greater than or less than 0.8. And we can figure out, or we can diagnose based on these ratios. Okay, so let's just watch a short clip on the VQ ratio and see what exactly can go wrong.
Hey everyone, I'm here to talk to you a little bit about ventilation and perfusion mismatches. So what we know is normal VQ is 0.8. 0.8. And what that means is these alveoli, and yes, these are alveoli, are getting well ventilated, and these capillaries are getting well perfused. And so what happens here at the alveolar capillary membrane is exchange of O2 and CO2. So we can say that this healthy individual has a good ventilation and perfusion, so a normal VQ. So let's talk a little bit about mismatches. Okay, so when we have a VQ ratio that is less than 0.8, what we see, let's put a little clot here. This is a little clog, maybe a little clog of mucus, could be a bronchoconstriction. But what we see is that our alveoli don't get well ventilated. However, we still have good perfusion. But still, right here, we're not going to have good O2-CO2 exchange. So what we call this is shunting. So shunting is decreased or no ventilation but good perfusion. And we see this in diseases such as pneumonia, and we can also see it in asthma. All right, so what happens if the opposite happens? What happens if our VQ ratio is greater than 0.8? What that means is that these alveoli are getting well ventilated, but those capillaries are not getting perfused. And what we call this is dead space. And the most common cause of dead space is going to be a pulmonary embolism. Again, you're getting good, adequate ventilation, but decreased perfusion. And again, it's interfering with the O2-CO2 exchange. So hopefully this clears up a little bit about VQ mismatches.
Okay, so just to elaborate on that just a little bit, here is a diagram that shows us a normal healthy VQ ratio. We are getting ventilation, so air flowing into and out of the lungs, and we're also getting adequate blood flow. Remember that blood comes in blue, it is not oxygenated. It flows through capillary beds where it is oxygenated, so we get this gas exchange here, and then it leaves to flow back to the left atrium red, right? And so again, that's a normal VQ ratio of 0.8. If there is perfusion without ventilation, right? So there is a blockage in your airways. Here we can see that the blood remains blue, right? So it's never really oxygenated. And so this is going to result in increased carbon dioxide, right? So the CO2 never gets a chance to unload into the air and be exhaled. It's just going to go around for one more ride, right? And so as the video said, this can result from pneumonia, could also result from pulmonary edema, right? So if you have lots of extra fluid buildup in here, there's not going to be as much gas exchange. On the other hand, if we have ventilation without perfusion, we call this dead space. Remember, we first started talking about the respiratory system, I told you about anatomical dead space. Essentially, anatomical dead space is when air can flow, but there is no actual gas exchange, right? And that's a normal part of our respiratory system. In this case, this is pathological dead space, right? There's something that is blocking the flow of blood, right? So air can come in and go out, but it's just kind of flowing in and out without actually doing anything for us. And so the example that the video gave was a pulmonary embolism, which is pretty much a clot that gets stuck in these tiny little blood vessels and prevents blood from exchanging gases. Okay, and so ventilation without perfusion is going to result in decreased carbon dioxide. Okay, and so we can measure ventilation and perfusion with a VQ scan. And so essentially what this this imaging technique involves is breathing in a radioactive isotope, so not dangerous, but an isotope that will essentially show up with a machine and give us a pattern of essentially where where air is flowing, right? And so here we can see that there is plenty of air flowing here, plenty of ventilation here, but we're missing some down here. Okay. Also, a radioactive isotope is injected into the veins so that, again, we can visualize where the blood is flowing. And so once again, we see that the entire region of the lung here is not getting perfused, right? Same thing here, chronic pulmonary embolism, we can compare the patterns between the perfusion and the ventilation to see where the problem is, to see what the problem is. Okay, so arterial blood gases, right? So we know that we match ventilation and perfusion so that we can essentially establish an appropriate partial pressure gradient within the alveoli so that we can get appropriate dissolving in the fluid of the lungs, crossing over those respiratory membranes, and ultimately loading onto or off of the blood cells. Okay, and so we, of course, monitor or regulate these different partial pressures. We regulate pH and we regulate bicarbonate. We'll get into that in our next lesson. As we'll also see in our next lesson, hemoglobin saturation as well. So I hope at this point you guys can somewhat appreciate that any kinds of shifts in the oxygen and CO2 levels are going to be pretty important, right? And our body is going to respond to them by changing ventilation and perfusion. And so before we move on here, I do want to show you this chart here, which breaks down the partial pressures of the different respiratory gases. Remember when we started our lesson today, I told you that the air that you breathe in is actually a lot of different gases all together. Each one has its own partial pressure and it moves according to its own partial pressure gradient. And so most of that air you breathe in is nitrogen, of course, but about 150 millimeters of mercury is oxygen. Okay, and so by the time you actually breathe that air in and it gets changed on the way down your bronchial tree and it finally gets to the alveoli here, the alveolar air contains about 100 millimeters of mercury of oxygen and about 40 of carbon dioxide. Remember that your last breath, residual volume, is mixing with your new breath, right, this here, and therefore you have about 40 millimeters of mercury, an increase in carbon dioxide because of the last breath, the last unloading of CO2. Okay, both of these move down their gradients, right? So 46 to 40, so CO2 moves from the venous blood into the alveoli. Oxygen moves from the alveoli into the veins, into the venous blood. And ultimately, by the time the blood passes through from the the beginning of the capillary bed to the end of the capillary bed, returning to the heart, the oxygen levels have increased to 95 or greater. Okay, and CO2 has decreased again back down to what we see. It matches the alveolar air. Remember, it is very soluble. And so when we use this fancy tool here, generally we see that our blood is almost entirely saturated with oxygen, right? Even if you're wearing a mask, even if you are exercising, even if you hold your breath for 2 minutes, right? The oxygen is going to stay about the same on in your blood. Okay, and so we're going to talk about that in our next lesson together. One final column here, the expired air. All right, so essentially the alveolar air is going to mix with the air that is in that conducting zone, that anatomical dead space on the way out. And so the air that you're exhaling is about 116, and CO2, right, still a little bit higher. Of course, you're breathing out all the CO2. So I bring this up because it always bothered me that when you do CPR, you are exhaling into the individual's lungs, and there's no oxygen in that, or there's very little oxygen in that air, right? Why are you, breathing this very low oxygen air into the individual? But if you think about it, the air that is coming out of your own lungs actually still has a reasonable amount of oxygen within it. And remember that in the conducting zone, right, there is no gas exchange. And so the first couple hundred milliliters of air that you are breathing out and therefore into your patient, right, that you're doing CPR on, is actually the same air that you just inspired. So you are literally just blowing the atmospheric air back into their lungs. All right, so I just wanted to throw that out there. Okay, so to wrap up these 4 factors, remember that external respiration, right, oxygen, CO2 exchanging in the lungs, is influenced by those partial pressure gradients. Right, we know that air is modified considerably on its way down into our alveoli. The respiratory membrane has to be thin, it has to be wet, it has to have a lot of surface area. The gas solubilities, right? Oxygen has a much steeper concentration gradient because it is less soluble. Also, oxygen has to be carried on hemoglobin, whereas CO2 does not. And ventilation perfusion coupling is critically important in order to maintain the right levels of oxygen and CO2 in our blood, particularly CO2, because that's what our body is regulating the most and will change our breathing and heart rate the most as a result of. Okay, so I want to end today with a clinical perspective. This is a short video on cystic fibrosis. This is going to come back. So if you're sticking around to the end of this lecture, you will benefit from this, right? So you'll see cystic fibrosis again. Think about how cystic fibrosis affects the respiratory system. We're going to add in the digestive system and finally the immune system, and ultimately what this disease is doing to the entire body. Enjoy.
A patient with cystic fibrosis is susceptible to infections of the lungs. This is due to a mutation that affects a protein on the surface of lung cells. Many different mutations can cause cystic fibrosis, but all of them involve a transmembrane protein called CFTR that functions as a channel for chloride to move in and out of cells. In this case, CFTR is less able to transfer chloride ions out of the cell compared to the functioning protein in people without cystic fibrosis. The channel is, in effect, locked shut. This inability to transfer chloride ions has an effect on the outside of the cell. In people without cystic fibrosis, there is a balance of chloride ions inside and outside lung cells, which maintains the right amount of water and salt ions in the mucus lining the airways. Cilia normally sweep the watery mucus from the lung lining, keeping the surface clean. In patients with cystic fibrosis, chloride ions concentrate inside cells and draw in water by osmosis. With less water, the mucus becomes thicker and cilia can't move. Flow is reduced, providing an environment for bacterial infection. But there are now drugs that can help patients. To find a drug, researchers tested over 200,000 small molecules to see if any would bind to the CFTR protein. Then, for each small molecule that had some binding ability, researchers chemically synthesized different variations of that molecule and tested them for the ability to improve the function of some types of mutant CFTR channels. They identified a drug that, when taken by patients with a certain type of CFTR mutation, binds to the CFTR protein, opening the channel and allowing improved ion transfer. This increases chloride ion flow and maintains a watery, clear mucus, which helps the cilia move more freely and reduces the risk of bacterial infection.
Okay, so just one of many ways that a single mutation can lead to body-wide effects. And of course, transcription, translation, getting all of these different pieces of this process exactly right is critical to the individual. So that is all for today. Thank you guys for listening. I'll see you next time.